Good evening, everyone. My name is Dr. Rajadhar. I head the Department of Pulmonology at Fortis in Kolkata. A warm welcome to you for the fourth and final in the series of advanced PFT workshops that have been organized by PACS and has been endorsed by the Indian Chest Society. A big thank you to Schiller for having given their support for these meetings. Today's session is on CPET Advanced. And the speaker today is none other than Dr. Deepak Talwar. I won't waste your time trying to introduce Deepak. I have learned from Deepak on numerous occasions. And I was telling him just before the meeting started that I'm especially nervous today because I'm going to just attend the master class and coordinate things rather than being a faculty in this meeting today. So I look forward to this session and learning about advanced PFT. So Dr. Talwar is the Senior Consultant Chairman at Metro Center for Respiratory Diseases in Noida. We'll do this session for about 2 hours. We would ask you to send your questions in during the course of the meeting, and we'll try and answer those questions at the very end. So without wasting further time, I'll hand over to Dr. Talwar. Deepak, all yours to start off the meeting.
Thank you, Raja. Good evening, everyone. You're always very, very modest. There is nothing which you do not know or what you need to understand more. That is very clear to everyone. It should be. And this is your modesty. And we all have seen it almost every day. And every day we see it, relish it and cherish it also. So today, yes, we have a little difficult topic. We are on the grand finale of this advanced lung function test. And I think nothing could be more difficult than an advanced CPET session, which is cardiopulmonary exercise testing. And no doubt we have seen in our previous series that people have heard about it, they know about it, but they find it complex, they find it difficult to understand, and they want to use it, but they do not know how to use it. So obviously, I think there are in fact a lot of limitations in utilizing this modality, which is perhaps one of the, as I discussed in the last meeting also in the basics, that it is one of the most important investigation for dyspnea of unknown origin, which is a very common scenario of presentation in pulmonologist practice, where they get lots of patients with dyspnea, and you really do not know whether this is clearly respiratory, cardiac, or multiple causes. And that's what we discussed last time, that in the exercise testing, what we need to do is elicit the organ system's responses. And we do it to such a level that the one of the organ system fails. And that gives us a clue that if this patient has got exercise limitation, is not able to have the amount of exercise or activity which is required for him, had he been normal, then which is the organ which is limiting. So it is stretching an organ to such an extent where that organ says or cries that I cannot do any more. And that's what you need to detect on this cardiopulmonary exercise testing. And we do understand that it's a test which looks very, very complicated, but all it does is basically just 3 things: that it measures the oxygen which you take in, carbon dioxide which comes out, the oxygen which comes out, and of course the volume of air which you move in with each breath. So it's a breath by breath analysis, and the analyzer has got 3 things to do. It is constantly online analyzer for oxygen, for carbon dioxide, and for volume. So you can actually look at the ventilation. You can see the amount of oxygen moved in, amount of oxygen which has come out, the amount of oxygen which was there, carbon dioxide which was there when, and of course the amount of carbon dioxide which you have exhaled out. So the entire respiration, which is a process in the mitochondria, which actually utilizes the glucose to produce ATP for contraction of the muscle, produces carbon dioxide by taking oxygen inside. So the internal respiration, which is occurring in the tissue level in the mitochondria, is going to be transported across the lungs, because it is the duty of the lungs to provide for that extra oxygen required by the tissues and take care of extra carbon dioxide which is produced by them. And that is what we are going to measure in a CPET test. And obviously the patient is going to make this by doing an exercise which is to the limit of limitation. What is the limit of limitation is when the patient says, I can't do anything more. So this is totally different from our leisurely test, which is 6-minute walk test or other similar kind of exercise test, in which the patient does it on his own will and is not stressed to the level where it leads to exhaustion. So this test has to continue till the patient says, I cannot do it anymore. And that's the point where you need to see this system, that is it the lungs ventilatory problem? Is it the cardiac problem? Is it the circulatory problem? Or finally, is it the problem at the level of the muscle or the mitochondria, which are probably required for the muscular contraction or the exercise to go on? So this is a simple picture which just tries to tell you the oxygen concentrations, the carbon dioxide concentrations, and the volume of flow during inspiration and expiration. You can see hardly any carbon dioxide. You can see that with every breath, you will get the oxygen in, you'll get the carbon dioxide out, and then the liters which are moving in. So tidal volume breathing, we know that the volume, but now exactly we will be looking for the amount of volume which has moved in and the amount of oxygen in concentration which has gone inside, and of course the one which has come out, and also the carbon dioxide. The test used to initially require where you need to collect the entire gas for the 10 minutes. So you can imagine the amount of bags which are required, and those bags keep on filling and it ultimately fills the entire room. But now we have online analyzers. So if you have an online analyzer, you can constantly sample breath by breath the amount of oxygen, the amount of carbon dioxide, and the amount of air being moved per second. But there are other measurements which are also done in the CPET, which are just ancillary one to make the understanding of the various organs to their level of limitation more easy. So we give a work to the patient to perform, which can either be done on the bicycle or the treadmill. We have discussed that last time. And we look at the maximum oxygen uptake, which is VO2 max. And obviously the maximum amount of carbon dioxide which has come out, which is VCO2. And we also have monitors like heart rate, ECG, BP, saturation. And we also do the other calculations which are required, like calculation of the anaerobic threshold. Anaerobic threshold, we have already discussed, is the point where the muscle turns from aerobic metabolism to anaerobic metabolism, because the oxygen supply is outstretched at that point of time and there is no more glucose available. So it tries to shift into an anaerobic metabolism where lactic acid is being produced, which will lead to increase in ventilation to take care of that metabolic acidosis which is occurring, which is the point which is considered as or called as an inflection point where we calculate the anaerobic threshold. We have discussed that last time also. You can do direct ABG measurements, serum lactate measurements, but they are most of the times not required. And very importantly, we use Borg scales or the modified Borg scales, which I showed you last time, to rate the amount of difficulty which the patient has in performing the test, which is progressively worsening. So is it the dyspnea and the leg fatigue? They need to be scored, and they need to be scored till the patient says, I can't do anything more, where he will say perhaps the dyspnea is so much he cannot do it, or maybe it's his legs which are going to give away if he tries to do any more exercise. So all these parameters which are being there, they are trying to correlate with the patient's effort, and this effort must go on till it is limited by the patient. And that is the point where patient will say, I cannot do anything more. So that's very important, that sub-maximal exercise test being performed on CPET is not good enough for interpretation to find out what is the cause of dyspnea in the patient, because it did not go up to the maximal limit. So the first point we always start looking forward when we look at the CPET results is, has the patient performed the test up to the level of so-called as limitation or exhaustion or not? Clinically, of course, we see and also ask the patient, and many times the patient says that it's their leg which is hurting, or they're too breathless, or they are completely exhausted and sweating, which you can see clinically also.
Deepak, can I add something?
Yeah, sure.
Quickly, so last slide, so quickly, so there's lots of parameters for someone in the previous slide. So there's a lot of parameters there. For someone who's starting CPET, what do you think the focus should be on? What are the basic minimum? We'll come back to this later on too, I know. But what are the basic minimum parameters you need to look at when you're starting off with CPET?
So now the question is, when you are asking for an exercise test in which you want to see whether the patient has got exercise limitation or not. And exercise is directly related to the VO2. So if VO2 is the first parameter which you need to see, And I am going to come to that you need to achieve more than 83% or 85%,
Sure.
whatever the parameter you take. And if you are able to achieve that, then obviously if most likely you do not have any cause of dyspnea, and whatever it is there, it could be something not related to the entire system uh, of the entire systems which we have seen, which include respiratory, cardiac, circulatory, and the muscular symptoms.
Right. Ran.
So I think this is a little tough thing. These are called Wassermann graphs. They are standard. This is 9 panels, 1, 2, 3 to 9. They are standardized panels, and they are very significant for reporting and for interpretation of the CPET, because each panel is trying to tell you some information about an individual component of the exercise testing. We'll come a little later because they are all jumbled up here, but this is how the report is going to come. The report will come this much in color, and also this much of cramped 9 panels on one page. So obviously you need to look at little more carefully for them. So we will go to panel one by one and try to find out what these panels are individually trying to tell us. And then we will come to something like, how to analyze them and go from step 1 to step 2 to step 3 and step 4, which are the 4 essential tests for reporting the once you have got already the results. The test modality to begin with is that we want to find out that what is the limiting factor that the patient is not, or the person is not able to perform his exercise. So why is he dyspneic on exertion? That's the question which needs to be addressed by CPET. And as I have stressed already enough, that you need to stress the cardiorespiratory system to such a level where it identifies that what is limiting the exercise. Is it lungs giving away? Is it the heart giving away? Is it the circulation which is going out of control? Or is it finally the muscle which is not able to perform? So at that point of termination of the test, you need to identify these four distinct systems to find out which was the system which was stressed out of proportion, where it could have never gone any further, and of course is the reason for limiting the exercise capacity in an individual patient. And I think Raja very rightly asked, what do you need to start to look at it? So peak VO2, maximal oxygen uptake, because when you need to do exercise, you need to take oxygen. And the amount of exercise you do is related to amount of oxygen which reaches there. So the oxygen uptake is the primary marker of the exercise capacity. And that's the first parameter which we look at it. And second is where this the entire exercise shifts from aerobic to anaerobic metabolism, which is the point of anaerobic threshold. These are the things which are very important, and obviously we'll come to it later on. But we do CPET not only for looking at VO2, also to look at the exercise capacity, but we look at for the level of disability. So in a lot of situations, you need to see that if the VO2 is like less than 40% of the uptake, the patient is really exercise limited, and this is a disability quality certificate for that person. Identifying the cause of dyspnea, which is causing limitation of exercise, is a most common indication in pulmonologist practice. You need to screen the patients when you have them with obviously a ventilatory diseases like COPD or ILD for other causes of dyspnea, which could be worsening the patient's symptoms rather than just our respiratory disease. So coexistent diseases like ischemic heart disease, peripheral vascular disease, pulmonary hypertension, or arterial hypoxemia, all of them can be there, and you need to identify them, that how important they were in limiting the patient's exercise test. Also, it helps us to plan the patients for the rehabilitation exercise training as to what level of exercise training to start with and how to build on it, and also to look at if there is any effect of the interventions which could be various in the respiratory field. And finally, it is also of importance from prognostic significance, as we discussed last time, that surgical risk. In fact, surgical risk is an important point to be calculated for patients who are undergoing for pneumonectomy or lobectomy with borderline respiratory reserve, where a VO2 max of somewhere around 14 ml per minute per kg is considered as an adequate one, which is good enough value to go ahead with a pneumonectomy in such situations. And of course, many other aspects of information can be achieved from the CPET. There are few contraindications. Acute myocardial, which is quite obvious, acute myocardial infarction, unstable angina, unstable arrhythmias, patients with acute endocarditis, patients who develops syncope or very severe symptomatic aortic stenosis, uncontrolled heart failure, acute pulmonary embolism, patients in severe respiratory failure, And of course, patients who are on oxygen cannot also be put onto the CPET test. There could be many other reasons, but by and large, the cardiac reasons are the most important reasons where there are absolute contraindications, and unstable patients cannot be put onto CPAT. So once we start this exercise test, we determine that, this individual who has come with this age, with this height, this weight, and this race, how much exercise capacity he is supposed to do. And this is according to the normograms. We use the same normograms which are used in the West. We predict that this patient should be able to perform about 100 watts, 200 watts, or 300 watts. So depending upon whatever, it can be like the intermediate figures, 140, 160, but we calculate according to his age, weight, and height, and race and sex, that this is the amount of exercise which needs to be done. The second point is that this exercise needs to be performed in 10 minutes. The cardiopulmonary exercise test, the duration of the test is 10 minutes. So if you decide that this patient has to do 100 watts, you will use 10 minutes every minute rise, so that by the end of 10 minutes you reach 100 watts. On the other hand, there are young and healthy people who might be actually required to do 200 watts. So in those patients, we need to, or those people, we would like to raise 20 watts every minute so that we are able to achieve 200 watts at the end of 10 minutes. The important point to remember is the protocol requires the CPAT to be done in 10 minutes because that's the time which is comfortable for the patient to perform the exercise. Once you extend it beyond that, most of the people are not able to do and the results go haywire. So that's why it is a standardized 10 minutes. Now the exercise test can be given to them in two ways, either the incremental or the continuous. So why I told you incremental is because every minute you keep increasing them till you reach the maximum, and you need to reach that by 10 minutes. Followed that is a recovery period. On the other hand, you can have a continuous one in which you can put the patient straight away onto one amount of work and then let it continue for a full 10 minutes till the time the patient comes to an exhaustion. So these continuous tests are less used. More commonly, we are using incremental tests in the laboratory, and these are more easy to standardize, as well as the results match very closely, because if you look at the VO2 uptake, it just parallels the workload increase. So W increase versus VO2 increase is almost parallel running. So it gives a very good idea as to how the oxygen uptake is going as the exercise is proceeding in an individual patient, what is his efficiency, and if the slopes change, then they always indicate that this patient has issues in the exercise capacity, which is primarily either the oxygen delivery or it is the oxygen utilization, which all will be reflected on the VO2 peak. So this is how it is being done. You can see that you can use either bicycle, you can see the treadmill. The idea of using ergometers, cycle ergometers, mostly in the laboratories are because they are cheaper, they are safer. You don't, it's not scary to see that the patient falls off the treadmill while they are trying to cope up with that. So less dangerous it is. And of course, very direct power calculation. 10 watts, how much VO2? So we know that the slope is per watt. So it is very easy to calculate. If you go on a treadmill, you need to do it on METs. So you need to transfer it into watts, then only you will be able to make a direct comparison. So a lot of calculation is required when you do a treadmill test. In fact, in the cycle ergometer, this is very simple because all the parameters come in direct relationship with what, how much exercise you have done. In fact, the first part of the exercise test is that he has done an adequate exercise or not. And if he cannot do it, then you start finding it that what was the reason why he could not do it. So it's very simple to do it on a cycle ergometer. Very little training required. Most of the people are able to do. But I think there were a lot of questions last time regarding patients who have got bilateral osteoarthritis, total knee replacements, who cannot be able to perform or sit on the bicycle. And such people are generally put onto the treadmill. And in treadmill, we get a little higher VO2. It's more functional because patients walk on it. It is good for giving them even oxygen prescription. And sometimes patients may find it more familiar. However, in the Indian studies, which we also published, is that Indian patients are somehow more happy on a cycle ergometer rather than on treadmill because they have been learning about cycling right from their early childhood. And this is something which they have learned already. So unless and until there are orthopedic restrictions, most of the patients are happy on cycle ergometer, and so are the physicians because of easy interpretation of these tests. So that brings us to first question, and now to Raja.
Sorry, Deepak, before I go to the question, in the previous slide, suppose there's a physician who has access to both. So has access to a bicycle ergometer, has access to a treadmill. What would your carry home message be? Would you use different sets of patients for both? Would you just go with the bicycle ergometer? How would you choose?
Right. I think very good question, Raja. Like we also have on one side cycle and one side treadmill, and in the center the CPAT. So we use cycle as far as possible, unless and until the patient says he cannot perform it. And they are the patients who are not ready to sit on the cycle because either because of their back problems or because of their knee problems. So most of the times that is the issue. The second thing where you would like to use is in where you seriously consider that the cardiac issues are going to come, and you are going to monitor them more better on a treadmill. Although on a cycle ergometer, it is the same stress test which is going on with the ECG recordings, but they are more amenable to, the tuning with the cardiac point of view is more on a treadmill. So if a patient is purely being looked after from a treadmill perspective, from a cardiac point of view, then perhaps a treadmill is better, but most of the times we'll go for a cycle ergometer.
Right. Wonderful. So audience, now is your chance. So what we do is, like you've done in the previous modules, we'll give you a question with 4 answers. I will be able to see what answers you've given in the form of a poll. And then between myself and Deepak, we'll discuss your answers and a little bit of evidence based on which we'll try and give you the answer. So the first question, which you can see in front of you, which exercise modality is least likely to yield exercise desaturation in COPD? So least likely being operational. Is it treadmill? Is it timed walking test? Is it a cycle ergometer? Or do you think it's all the same irrespective of what you use? And your time starts now. So while we are waiting, we heard Dr. Talwar saying a little while ago about the fact that with treadmill you attain a higher VO2 max. So that's something maybe to keep in mind when you're trying to answer this question. You also heard the comfort of the Indian patients with a cycle ergometer. So least likely to yield exercise desaturation.
I think that's also important from the perspective of our respiratory patients, because some of them are going to desaturate very badly.
Sure. So interesting answer, Deepak. So about 50% of people have said that a timed walking test is the choice which is least likely to yield exercise desaturation in COPD. And then there's about 12% who've said treadmill. There's about 18% who've said cycle ergometer. And then a good 1/5 have said that it does not matter. They're all exactly the same as far as exercise desaturation is concerned. So 50% time walking test. What's your take, Deepak?
So Raja, I think you had initially also asked about it, when do you choose on a treadmill versus a cycle ergometer? I think you were giving a hint that if the patient is very hypoxic, likely to become very hypoxic during the exercise testing, you would rather avoid them to put on to where you can achieve more. That is the treadmill. So I think you had given that. They're not all same. Definitely, there is a difference in that. And we do see in such a situation that we find the treadmill leads to a little more desaturation. But it ultimately depends upon the pathology, which is the underlying cause for it. So if they have a gas exchange abnormality, it will be more profoundly coming out on a treadmill test. Otherwise, if it is a simple desaturation, which is like 4% to 5%, it can be very easily picked up on a cycle ergometer also. Only thing is you need to know that if you change one modality to the second modality between two exercise testing, then they cannot be comparable if the device was or the modality was different. And you can see this actually, it is trying to show you that the VO2 is, when you go continuously on a load, they're almost parallel to each other, irrespective of how you set in. So like whether you give it to somewhere around 5 watts per minute, whether you go to 10 watts per minute, whether you go to 20 watts per minute, it always the relationship between the VO2 and the load is maintained with the slopes being close to each other. So the only thing is that the achieving the predicted watt is actually indicative of the normal capacity. So you need to see that you should be able to achieve it in 10 minutes. So very important to see that the exercise capacity has to be calculated, and then you have to set your cycle. It's not that a routine like 10 watts per minute can go for every patient. It may go good for patients who are 50 years and above and who have some disease, but in people who are like 40 years, younger people, where the expected load is like 200 watts. So if you put them 10 watts per minute, they will finish the exercise very well, but it is not a maximal exercise test. It will be a sub-maximal exercise test. So this is the ERS long back in 2007, to the indices, I think, which again, Raja has asked very specifically, what are the important indices? So VO2 peak, as we discussed, is decreased in across everything. So that's the first parameter which will show you that there is an exercise limitation. And then you start working on anaerobic threshold, arterial desaturation, and obviously you also look at the slopes, which we are going to discuss little later. So that brings us to question 2.
So Deepak, I've got another question before we go to this one. So in the previous question, it talks about heart failure as a cause of crossing the anaerobic threshold. So there's a plus for heart failure, whereas there isn't one for airways disease, interstitial lung disease, etc. So is that specific for heart disease that your anaerobic threshold comes earlier, or how do you interpret that particular chart?
Okay, so they are coming in subsequent slides also, Raja, but the issue is the anaerobic threshold means that the blood has outstripped the exercise. So we think that heart failure is a very important cause of it, because it won't be able to push the blood flow. So after the exercise, the failing heart will not be able to provide the blood flow to the muscle, and levels will fall down and it will shift to anaerobic metabolism early. So anaerobic threshold comes early, which is less than 40% of your exercise capacity in patients with heart failure. That is one of the things. But second, also important reason is the patients who have got muscular diseases. Even in them, you won't be able to get an early, you will also get an early anaerobic threshold, like mitochondrial diseases, so diseases of the muscle per se, which cannot extract oxygen. So they will also get a similar kind of pattern.
Sure. Grand. So thanks, Deepak. So coming to the next poll question. So the question is the slope of the relationship between oxygen uptake and work rate for an incremental exercise test. And then your choices are, is increased following endurance training, is decreased following endurance training, can be normal in obese individuals, and fourth, is typically greater than normal in patients with coronary artery disease. Your time starts now. I don't think that this should be a big challenge. You heard Dr. Talwar talking about this a minute ago, and I'm sure he's going to show us some evidence as we go along as to the relationship between VO2 uptake and the slope.
So when you look at the VO2 uptake, you look at its value and also look at the slope. So there are two things which are possible there to look at it. So VO2 maximum, of course, is the amount which is going to tell us whether the person is able to perform the exercise or not to the maximum. But the slope tells you how the process of exercise has gone through. So can it be improved or can it be different in other diseases? So that's, I think, the whole idea of this question.
Sure, sure. So Deepak, about a vast majority actually say A, which is increased following endurance training. Then there's about a fourth, so about 27% who say is decreased following endurance training. And then we've got a little bit of the rest. People generally don't feel can be normal in obese individuals. And then there's a 10% which say typically greater than normal in patients with coronary artery disease. So your comment about A and B, Deepak.
Okay, so I think it's very important for us to understand that the slope cannot change even with training. So slope remains the same. Only if you are a very good athlete, you will be able to increase your VO2 max to a very high level. So that's what the training you are going to do. As far as the slope, that's a constant relationship. And in fact, it only fails when patients who have got heart failure or cardiac disease. So in fact, the slope changes whenever there is a circulatory changes, and that is primarily cardiac disease. And in obesity, it is just shifted but remains parallel. So the slope doesn't change even in obesity. So when there is a morbid obesity, when we do the CPET, we correct the VO2 to the per kg of body weight. of an individual. And then we find that the slope comes out to be the same, which is required for that, like whatever we are talking about, it is supposed to be 10 ml. So it remains the 10 ml if we correct it with the obesity, and the slope will not change. So what we change with the exercise and the trainings and everything is primarily the value of the VO2 max, which we are able to achieve. So what we say that this is VO2 max for an individual, that's true, but that also depends whether he's sedentary, whether he is an average healthy individual, or he is a really very well trained athlete. So very well trained athletes can increase their VO2 max to almost about 25 to 50%. That's what the training matters actually, or training does to these patients. Coronary artery disease or cardiac diseases, they change the slope like we are showing here. You are able to reach and get some VO2 peak, but then it goes very slowly because the blood supply by the cardiac system, the circulatory system is slow. So it is gone, oxygen is reaching there, they are able to perform exercise, but not at the level or at the rather the slope which it is supposed to do. So that's why it's not only the value, but also the slope needs to be identified. And that brings me to one point that there is a confusion about VO2 max and VO2 peak. So these are the terms which are interchangeably used. But what we need to understand is VO2 max is predicted. So this individual, this height, this weight, this sex, this race is expected to achieve this much of VO2 max. That is predicted normograms. That's what we do not have for India. So we are still using the Western standards only, higher, true. But that is the max which is predicted. The other important point is that when patient is doing it, he may not actually achieve that 100%. He might stop short at 90, 80, 70, whatever it is. Whatever he achieves maximum is called VO2 peak. It is not reached the max, but it is the VO2 peak for an individual person. Since performing actually a test, we even do not know whether it is actually a normal variation for him, or he is the one who is supposed to achieve much more than that. Had it been earlier or after the intervention, it will change. We do not know. So the difference between these two terminologies is what is he is expected to do and what he has actually achieved. So whatever you achieve maximum VO2 is a peak. If it is close to max, then fine. But if it doesn't, there will be a gap left behind between the two, and that will be the gap which has to be not more than 17% or 15%, which is the acceptable standards for interpretation of the VO2 peak vis-a-vis VO2 max. And that brings us to the third question. Raja?
Yeah, sure. So third question, VO2 peak of more than 85% rules out any exercise limitation. Is that true or false? You can see Dr. Talwar smiling there. So that's always when there's a trick question. So true or false, A and B, and then I don't know is the third choice. So I know you're going to speak about this, Deepak, in a few minutes. You'll talk about the 85%. I'm just looking for the results. So 60% of people say that it's true that VO2 peak of more than 85% rules out an exercise limitation. But there's a good 40% who say that it's false. And I don't know.
So I think both the choices are correct. People are very right, because what is happening here is that we are predicting that this person has this much. So patient might be having actually earlier much more than that, and it has decreased now since he has performed a test before. So we do not have exact idea. But by and large, yes, if you have achieved 85%, practically it means to us is that there is no exercise limitation. But there is only one caveat there, and that caveat is that for an individual person, we do not know whether this 85% was really 85% or not, because 110% of his peak before, or max was 110%, then obviously coming to 85 itself is a decreased exercise capacity. So like what it tries to tell you is this question, that if you get that VO2 is achieved is actually 85%, and patient still complains of dyspnea, there might be a mild disease which is going to be overlooked, considering that we do know that patient had an originally how much of VO2 before he had exercise induced dyspnea or whatever were his complaints coming up at that point of time. But this is very uncommon, because most of the times when we get the patients, they are already limited to much below 85, where the things are more clearer. It's only in the borderline cases. But by and large, the first step for interpretation is whether the patient has achieved VO2 max or VO2 peak of his in up to 85% or not. Is it more than 84, 85 or not? So some people take 83, more than 83, somebody take 85. So it's basically 84 to 85. So if he has achieved that, then obviously a significant disease is ruled out. You know, there could be anxiety, there could be very, very early bile disease, and perhaps you would like to repeat the test in 6 months' time or something like that.
So
The
Deepak,
degree of impairment.
Sorry, Deepak. So when you talk about a comparison, would that not be true more for athletes where you're assessing performance rather than for normal individuals who are going to exercise, isn't it?
That's very correct. Very correct. Raja, you have picked it up and pointed out very rightly that it is of more importance, particularly to the athletes who are undergoing training. And of course, to see the effects of the intervention which you are doing. It could be any intervention, but that will be on a longitudinal basis, give more idea as to which way the things are going in this situation. You are very right. So severe is less than 40%. So if your VO2 peak is less than 40% of predicted, that is considered as severely impaired people. And these are the people which are considered as handicapped in the West and given all the privileges which are given being for the handicapped people. They are also very important, also a very important parameter for compensation purposes, which are occupational or non-occupational, depending upon how much your VO2 because of whatever you have done in the occupational environment. So this, as I said, you know, this parameter is generally considered 83% for both men and women, but it can be higher. It can be kept just 80% in people who are more than 70 years of age. And of course, extreme body dimensions are also very important. People who are very thin or very obese, then again, the values will be different, and you need to interpret according to the weight per kg of that person, VO2 per kg, VO2 ml per kg you need to. So as I said, you know, it is like these are the only two conundrums which are there. Sometimes we might not be getting the VO2 peak in isolation coming up for the reporting of a decrease in exercise capacity. And that brings us to the fourth question, Raja, because VO2 peak is the first test report which you need to see, as I said.
Sure. So we now come to something that Dr. Talwar has actually alluded about a few times, and we'll go into some details about this, I know. So increase in ventilation in response to exercise below the lactate threshold is typically a linear function of, is it increase in tidal volume? Is it increase in pulmonary CO2 output? Is it an increase in pulmonary oxygen uptake? Or is it in the increase in breathing frequency? So those are your four choices. Go for it. So when we are talking about lactate threshold, we are talking about the anaerobic threshold, isn't it, Deepak?
Yeah, so we are talking the anaerobic threshold and lactate threshold and ventilatory threshold are the three terminologies which are interchangeably used in the exercise test. We discussed it last time. And I think this question is primarily again trying to remind that, you know, what drives the respiration. So that is why I think in last lecture also we discussed you need to increase your ventilation, you increase your tidal volume, you increase your respiratory rate, but in response to what? Is it which is the most important thing which drives the ventilation? So that's why this point has come up here.
So we got a split house, Deepak. So there's 50% of people who think that it's related to increase in tidal volume, and there's 50% who think it's related to increase in breathing frequency.
So I think there's a confusion about response to exercise.
Yeah.
What is the basically the relationship with the exercise? So these are the two different things, response and the relation. So I think everybody what they are trying to tell us is that we are looking at increase in ventilation by increase in tidal volume and respiratory rate both. We discussed last time that respiratory rate can go up to 50 and tidal volume can reach almost 60 to 70% of their vital capacity, and that's the maximum you can reach. And after that, it becomes so uncomfortable with the respiratory system that it cannot go further. So there is a lot of respiratory reserve always left at the end of the exercise in normal people, because that is impossible to achieve and get into that much of tidal volume at that much of respiratory rate. But what closely goes with the ventilation is actually the CO2. CO2 is the one which determines a linear relationship between the exercise versus the ventilatory system. And the moment anaerobic threshold comes, the increased carbon dioxide produced just upsets this linearity and change that linearity. And the importance is to change that linearity point to find out where is the anaerobic threshold happened. So this is exactly the principle of finding out what is the AT. So we can't keep on, we can't put in a IV cannula and do the serum lactate levels continuously. It's not possible. So we need to have a surrogate marker to identify where is the anaerobic threshold has come. So as I think we started from the beginning that you look at the amount of exercise individual has done, the maximum oxygen uptake which has gone, and then whether the anaerobic threshold could be achieved or not. The patient did the exercise at the point where the change from aerobic to anaerobic happens, whether it happened or not in an individual. So to identify, this is the important thing, because what upsets the balance is the CO2. So the moment the VCO2 increases suddenly, that is in response to washout excess carbon dioxide which is happening, primarily because this now anaerobic metabolism produces more carbon dioxide than the oxidative metabolism. We know this is the time where you need to identify this on a graph, that this is where the anaerobic threshold is happening. If the patient prematurely stops the exercise, it will never achieve. This is very typical in respiratory patients. So they have any respiratory reserve. So by the end, this is 3 to 4 minutes of exercise. They have not even completed their aerobic metabolism. This point of AT comes, this stops the exercise. So many a times we come up with the exercise test in which there is no anaerobic threshold, to identify what was the reason why the anaerobic threshold didn't come in this an individual. And most of the times these are patients either didn't coordinate, they were poor coordination to do the test, they were not willing to carry on with the test, terminated prematurely, or they are patients who are ventilatory reserve, which can be easily seen by the ventilatory parameters. So this is typically, you can see the lactate threshold. What is happening is that suddenly the lactate starts going up. This is, you can see, around 80% of the VO2 max. So normal people get about 80 to 85%, but it's a huge starting from here. So in fact, very difficult to identify a point where it suddenly turns. So what we do is what is called an area. It's called a zone. So anaerobic threshold is more or less, it is considered as a zone. So you pick up a zone and try to see the lowest part of the zone being less than 40 or not. If it goes below 40%, that is where it was not expected to happen. So there is somewhere there was a blood supply could not reach the muscle, and they had to shift their metabolism from aerobic to anaerobic early. So that is what we need to identify by looking at the anaerobic threshold. But as I said, we don't do the lactate level. So what we try to look at this, what is the sudden change in the VO2 and VCO2. So this is something which you can see, this is the time, and use time, work, because they are going by a continuous same thing as is every 1 minute, the work is also increasing. In this axis, you can see there's a time going on, or it can be even work, doesn't matter. But the two curves are seen, the red and the blue ones. Red and the blue ones. So what you can see is one is the O2 and another is the CO2. They are going together. They are going and chasing each other closely. And suddenly the red one, which is the CO2, you can see it crosses the blue line, the oxygen one, and goes above that. So that means now the carbon dioxide production is more than the oxygen which is getting inside. So this is the point which is the anaerobic threshold you can identify. But these graphs sometimes don't typically show us so well change which is happening here, which is exactly the point where it has crossed. Lactate is a different, because lactate will have buffers in the blood, and by the time you see the lactate rising, there would be certain period of time in which the blood would have actually tried to dilute the effect of lactate. But increase in CO2 is something which is happening immediately as soon as you find there is some amount of acidosis coming into the blood. So this is one of the graphs which you can use to identify, and that brings us on anaerobic threshold. So I think VO2, what, and then anaerobic threshold. So Raja, that is why this question has come at this level.
Sure. So I'll read that question, and there's an audience question which I think is relevant, and I'll ask you that while we're waiting for the answer, Deepak. So the question in front of you, anaerobic threshold, it's a zone rather than an accurate point. Second choice, it's normally at 85% of the VO2 peak. Third, it's easy to be localized on a VO2 graph. And fourth, it may not be seen in healthy athletes. So those are your four choices. And while we are waiting, Deepak, quick question. There's Dr. Shahestra Buddhe who says that on a bicycle ergometer, it's very difficult to achieve a VO2 max. So we've been talking about what modality to use, whether it's a treadmill, a bicycle ergometer, and so on. So what's your comment on that? He feels that getting a bicycle ergometer to achieve VO2 max is the challenge.
Well, yeah, 100% is, if you want to see that VO2 peak becomes VO2 max in an individual, very rarely happens. Very true. That is true. So, but by and large, they are able to achieve 85%, 90%. It does happen. If they are not able to do, it is because of the poor effort of the patient that we will be able to identify in this. So that still considered as a choice to perform this, because we are not achieving 100%. What we are trying to achieve is whether we are able to achieve
Sure.
or not.
Sure. So Deepak, the audience has been listening to you carefully. So they've gone for choice A, which is it's a zone rather than an accurate point. That's about 65% of people. About 25% have gone for point C, which says it's easy to be localized on a VO2 graph. And then there's minuscule numbers for the remaining B and D on there.
Yeah, so I think zone and 85% were the two clear in the last couple of slides very clearly. So you can see that actually the 80, it's basically not a single value which is coming onto it, but the rule of thumb is that it needs to be above 40%. So if it's less than 40%, then obviously we consider it that the anaerobic threshold occurred too early. So you need to find out why it occurred too early, because then the patient is not able to perform the exercise, because it's a very painful to carry on the exercise once the anaerobic threshold has come. You might be able to do not more than that. So after the anaerobic threshold, the amount of exercise is very less. Maximum part of the exercise is prior to the 80 level which comes. And of course in older people and elderly people, it may come even at a later stage, but that is okay. This is another method like ventilation. What happens to ventilation? Ventilation increases with the exercise. So if you have more carbon dioxide produced in the body because of threshold coming in, then you need to do more, increase your ventilation more. So ventilation curve also suddenly increases, and that is also can be identified on a V slope. So these are all basically where the slope suddenly shifts. So whether it is occurring on VO2, VCO2 slope, is occurring on a VE slope, so you can actually do this. The important thing is most of the times the machines will try to look at it by the figures and other things and put a line there, but this line according to them. So many times actually we do manual things rather than going by the value for looking at the anaerobic thresholds. So the best fit lines can change whether it is done by machine or it is done by you. But when we see the results, we can easily change it, and it is editable on the machines, that you can edit it and then make these lines and see that, okay, I feel this line is better. Cutoff of this V slope is coming at the level which might actually change the anaerobic threshold. So clarity of this varies. Obviously it is not very clear in patients who are on beta blockers, very elderly people, or people who have got dilated cardiomyopathy. So the healthy people, we will be able to identify where is the anaerobic threshold. In the training, what they are trying to do is they are trying to push their anaerobic threshold to as far away at the end of the exercise as possible. So those who are marathon runners, that's their business, as far as possible, maintaining the exercise to a level where it is kept as far away as possible so that they can perform marathon activity in which to go. There are other slopes also which you can see, like I think all the values are given. The zone is being, many times what happening is the levels are coming very slowly changing, so you cannot actually pinpoint. So in that case, what is important for us is that the zone has occurred. So that means the change has occurred, but we might not be able to pinpoint it. So 10% there, 10% there, that's okay. So that's why we identify it as zone. And generally that's why the figure also, some people want to say 35%, some say 40%, some say 45%, but by and large accepted by the standards, by all the CPET labs, is that 40%. You should be able to achieve 40% for them. So then we go to ventilatory equivalents. So this is a little tough thing we discussed last time also. So what it means is that to remove 1 liter of oxygen or 1 liter of carbon dioxide, how much of ventilation is required. So this is basically indicators of how efficient your ventilation is. So if the ventilation is not efficient, that means that there is something wrong which is happening in change of gases. So that is why this is considered as a parameter of gas exchange. So it is a parameter which will try to pick up that something wrong is happening at the gas exchange level. And it is also seen in hyperventilation, because if you wash out too much of carbon dioxide by increasing your ventilation out of proportion to what is happening to the oxygen, then that is perhaps, if it is not explained by gas exchange in an individual, which we will have other parameters also to look at. If you get only one single parameter, that CO2 is getting washed out much more with more of ventilation required for the patient, then there is a hyperventilation syndrome which is related to anxiety, which can be picked up in the CPET curves. And very important here, these points that you are seeing, there are minor fluctuations here. If it's a hyperventilation syndrome, we find huge chaotic kind of curves of ventilatory threshold which gives us an idea that the patient is changing ventilation too fast, and the CO2 is changing in regard to that ventilation which is happening, which is primarily anxiety induced. So we can pick up those kind of things on these kind of graphs. And this is a value which is generally taken at 80. So generally you need to be on the CO2 less than 30. So if you are having more than 30, that means you have more carbon dioxide to handle. So obviously if you have more carbon dioxide to handle, that means there is some gas exchange abnormality which is happening, because CO2 is primarily responsible for the gas exchange there. And then obviously end tidal oxygen and end tidal carbon dioxide. We know that we are looking at alveolar one, and which is coming at the mouth level. So we can actually look at it, but if arterial also, arterial gases can be done, but we hardly ever use arterial gases. So normally there is increase in oxygen at the end and decrease in carbon dioxide. But if there are changes here, that again shows that there is a gas exchange abnormality which is coming up, which we'll discuss in a little later one. And this is a little composite picture which is trying to tell you what happens at the lactic threshold. So you can see that ventilation suddenly increases, VCO2 suddenly increases, O2 is trying to match, but then the VCO2 has outstripped now. So ventilatory equivalents, you can see that they're not changing at the anaerobic threshold, but they just change their directions, because now there will be more efficient ventilation if present. Will try to manage and cope up with the ventilatory thresholds there. The carbon dioxide falls, the oxygen increases, and then lactate levels, bicarbonate levels, and pH levels, if you are able to maintain the ABGs, then you can do. So these are physiological responses which are occurring at the AT level, and this is also very important to analyze with the exercise test. Many a time precise location is not possible, we have discussed, and there are certain clinical indicators also. Like if the patient is profusely sweating, that means there is a lot of catecholamine release, there is increase in systolic pressure, and this patient is really showing exhaustion, which shows that probably if he reached the anaerobic threshold already, because this is primarily because of increase in catecholamines. So these are generally considered as more of exercise training for athletes, where it is difficult to identify the anaerobic threshold very clearly. So if it is not identifiable, as we discussed before also, able to see it at all. So it is either the patient has terminated the exercise prior to that, which could be either the patient willing to perform the exercise, like what is called as poor effort. It could also be because of the obstructive lung disease. Respiratory reserves have already declared that they cannot carry on with the exercise any further. So aerobic metabolism, and the exercise ends there. But it also is a very important, as I think Raja has said right in the beginning, the cardiac causes, dilated cardiomyopathy, heart failure patients, patients on beta blockers. It's again the reason where it may not be easily identified, or it has come too early. In elderly and obese people, again, it is a challenge to identify them. But if you are not able to identify, you can look at the values where the PCO2 suddenly, the VCO2 suddenly starts increasing. So breath by breath, when you're looking at the chart, actually you get every 10-second records coming up. So that will also tell you that how the VCO2 has suddenly, which was coming to like 600, 650, 610, 20, 30, it was increasing regularly, and suddenly it takes a jump of 50. So that itself shows that this has happened actually finally. So you can use other methods to identify whether the anaerobic threshold is there or not. If it's truly not there, then you need to find out why it did not happen in an individual patient. And patients are very common not to achieve anaerobic threshold at all. That brings us to the first part of it, that whether the test was maximal exercise test or not. So as I said in the beginning, exercise to the limit where you say that you cannot do anything more than that. So how can we tell that? That most of the times the tests are actually sub-maximal. That is why they are not interpretable. Need to make the patient suffer, that is right, but how do we identify that? So the identification is primarily looking at RER. So these are, we showed that last time also. We'll again go one by one, but one of the graph is actually the RER. So RER has to achieve, you can see that it goes beyond 1.1. So this is the respiratory exchange ratio. If it goes beyond 1.1, that means patient has done his maximal effort. If it is below that, that means the patient has not put in the complete effort, and the anaerobic threshold not coming or not visualizing at all is probably because the exercise is sub-maximal and it's not a maximal exercise. So that's the caveat. This test requires exercise to be done to maximum. And this is the parameter RER, which is very important. We have discussed anaerobic threshold. This is how we go about it. So the panel 1 graph which comes is a ventilation versus exercise test. So you can see as the exercise test, the exercise keeps increasing, the ventilation also keeps on increasing, and then it suddenly starts increasing. If you have two slopes, you can see that there is a V point which is being formed there, which is anaerobic threshold, which we have discussed already, that this primarily comes because we are looking at the sudden change in ventilation to where it increases much more. And that much more is primarily because it is closely matching CO2. The job of ventilation is not to allow the CO2 to increase. That's the important point. So to maintain that, it will suddenly increase. You can see it here, that patient did achieve that maximum exercise, and perhaps the last 20% is the done in which the V suddenly increased. So about at 80% patient did achieve his anaerobic threshold where the ventilation increased suddenly. Second graph is oxygen pulse. Last time, I think we spent a lot of time on discussing oxygen pulse. Oxygen pulse is a surrogate marker of stroke volume. So this is the beautiful non-invasive method by which you can get an idea of what is happening to the stroke volume when the patient starts exercising. We did discuss that the normal stroke volume is basically the oxygen pulse only have one more factor, that is the arteriovenous oxygen extraction. This is basically, we have used the fixed principle for that. We have discussed that last time in great details. And oxygen pulse, which is like on one side, you can see here, it also increases with the exercise, and towards the end only it is going to plateau. So the stroke volume keeps on increasing. We have seen that it increases almost about 2 to 3 times, up to 4 times it can increase with an exercise. And the maximum increase comes from the heart rate. So the heart rate increases much more, but stroke volume also increases, and it steadily increases with the exercise. Only patients who are cardiac patients will not be able to achieve this constant increase in the stroke volume and will slowly plateau off. So early plateau of this oxygen pulse, which is the indicator of a stroke volume, tells us that patient has a cardiac limitation. So this graph, panel 2 graph, is very important to identify cardiac limitation. You can see that there's a plateau which has almost come towards the end. There's hardly any plateau. But if this graph would have gone like this from here, that would have given us the hint. I'm going to show that a little later. Then the panel 3 graph is a VO2 peak graph. You can see on VO2 on one side, VOC2 on the other side, and you can beautifully see that how the CO2 graph crosses the VO2 graph, which is showing the anaerobic threshold beautifully. So many a times we clearly get the 80 level very clearly from this graph, which is trying to look at the anaerobic threshold. And of course, the VO2, VCO2 is matched to the work or the time. You can take anything on the horizontal axis, they are equal. Then we come to the panel 4, the second row, in which we are now trying to look at the VCO2 as well as the, VCO2 as well as the heart rate. We can see here, there is a heart rate graph which is going on, and it is increasing. And we know that The primary increase in cardiac output is because of increase in the heart rate and also because of the stroke volume, but major change occurs in the heart rate. So heart rate keeps on increasing till it reaches the heart rate predicted max. So this graph, which is again trying to match up, we can again see that VCO2 is there again on this, and wherever the VCO2 is there, it can be also looked at the determination. Now, once you reach the heart rate predicted maximum, that is age minus, 220 minus age, that's the general formula which we use, we don't expect any heart rate reserve to be left. So if there is a significant heart rate reserve, which could be like 5 or 10 or 15 beats in an individual patient, it happens in patients who have respiratory diseases, patients who have put in their poor effort, patients who are deconditioned, or patients who are already on drugs like beta blockers and calcium channel blockers. So it's very essential for a CPET test to see if the patients are on beta blockers or calcium channel. Otherwise, they will be led to what is called as a chronotropic incompetence. Second important thing is the slope. Slope is also very important. If this slope, rather than going this, goes straight up, it shows that there is an acute response on heart rate with increase in exercise. So what it means is stroke volume didn't increase. So that is why heart rate had to compensate for increase in cardiac output. And instead of slowly increasing, it just went on and shot immediately up to increase the cardiac output. That also happens in a cardiac output. So same, this VCO2 heart rate graph, which is panel 4, is trying to look into the heart rate reserve, which is there, as well as the slope of the heart rate. To panel 5, which is VE over VCO2. This, I think I said right in the beginning, that VE always tries to match the VCO2. VCO2 increases, then the VO2 also has to increase. The same slope which is there. And this is again very efficient graph for looking at the gas or again at the cardiac efficiency. So these are primarily the gas exchange graphs, but can also be affected in cardiac insufficiency, which we are going to discuss later. And then these ventilatory equivalents, how much of oxygen and carbon dioxide per liter of ventilation. So you can see that as you start doing the exercises, there is improvement. So the ventilation becomes more efficient, both for oxygen and carbon dioxide. There is an anaerobic threshold which is to be achieved around at the values of 34 to 30, 34 for CO2 and 30 for oxygen. And then after this anaerobic threshold, they start increasing. The oxygen crosses over. Carbon dioxide is the washout of carbon dioxide excessively keeps on going by increasing the ventilation. So they don't increase much. So you can, this is a typical picture which you get, and this changes also on hyperventilation. So this graph is very important, not only for gas exchange, but also for looking at hyperventilation. So this is a slope about 30 for oxygen and 34 for carbon dioxide. These are the values, you can see that. And of course, this slope will change with CO2 when there is a gas exchange abnormality, that is the VDVT. So if the dead space ventilation increases with the exercise, then the slope will also increase. But that's not supposed to happen in normal people. The ventilation perfusion improves with exercise. So the dead space ventilation is supposed to decrease. So if it doesn't happen, this VE over VCO2 will change, and that indicates the gas exchange abnormality. That brings us to tidal volume graph. We have discussed about tidal volume and respiratory rate both increasing with the increase in ventilation required with the increase in exercise. So how much it increases? So you can see that the tidal volume increases, and we discussed last time, it can't approach up to the inspiratory capacity. So it just falls short of the inspiratory capacity. But of course that the total vital capacity, it reaches almost about 70% of that. That's maximum the tidal volume can increase. So normal tidal volume is about 450 ml. You can go up to maximal about 2.5 liters or 3 liters. Beyond that, you cannot achieve in the tidal volume. But also it will depend upon the type of disease. So in ventilatory disorders, if whether it is obstructive or restrictive, we know that the one disorder will respond more by change in the respiratory rate, that is the interstitial diseases or restrictive disorders. And in obstructive disorders, we will try to increase the tidal volume more. We will try to increase their tidal volume more. But then because of the dynamic hyperinflation, it may not increase. So we need to not only look at the tidal volume, the minute ventilation, the respiratory rate graphs on the ventilatory limitation, but also to look at the flow volume loops as to whether they are causing limitation or not, which is going to come in one of the later slides. Breathing reserve, everybody has already learned last time. Everybody was 100% correct that when you are looking at ventilatory limitation, you need to look at the breathing.
Deepak, I think we lost you for a moment there. So if we sort of start off again, yeah, Grant, thank you.
Can we see again?
Yeah, absolutely.
So I think there was some issue. So you can see, there is a huge breathing reserves. You can see about 30% of them left. So I think I said in the beginning itself, when you terminate your exercise, even in a normal, healthy athlete people, there will be some amount of breathing reserve left because you cannot use entire your vital capacity and the respiratory rate, which is above 50 in an individual patient to sustain the exercise. So some breathing reserve will left. But if you find that there is no breathing reserve left, so that if the patient would have tried to do the exercise, the lungs wouldn't have allowed him to do it. And that's the respiratory limitation. So this graph is very clear to look at it. If this dips down to a lower level, that is less than 15% or 20%, that shows that the breathing reserve was minimal or not there left at all. In these situations, we know it is a ventilatory limitation. So panel 8 is for that. And this is again trying to tell you the same thing, that ventilation can go on, but it cannot go on because the patient cannot achieve the maximum voluntary ventilation for more than 12 seconds. So that's why we do the test also for 12 seconds. We don't do it for even full minute. So if you have to perform it for 5 minutes on an exercise test, you cannot do it. So that's why it's not a limiting factor for a normal human beings. So if it is there, breathing reserve left, it should be left in an individual person. If it's not there, that is pathological and indicating of ventilatory limitation. And the last panel is the carbon dioxide and oxygen end tidal volumes. So end tidal concentrations are very important again from the gas exchange point of view. So if the CO2 is after the anaerobic threshold, the CO2 starts falling because efficient ventilation is trying to push out the carbon dioxide. But if it doesn't do that, then the CO2 doesn't fall down. And if the CO2 remains high at the after the maximal exercise, after the anaerobic threshold to the maximum exercise, that shows that there is a gas exchange abnormality which is precipitated by the exercise testing, which was not there at the baseline. So again, this is a gas exchange abnormality limitation which we are saying, trying to see. And the other is about the oxygen. So you can see that as you start doing exercise, the alveolar oxygen increases and the arterial oxygen falls down, and the difference is about 30. So if this difference is more, so that means again there is a gas exchange abnormality. But more easy to look at the saturations. If there is a more than 4% fall in saturation, or the saturation at the end of exercise is less than 94%, that again shows that there is a gas exchange abnormality, which is primarily you need to find out whether it is ventilatory or a pure gas exchange abnormality disorders like pulmonary hypertension. End tidal PCO2 is a very important parameter, is an opportunity to look at the pulmonary gas exchange during the exercise. And you can see that this, if it increases at the end of the exercise, that shows that definitely there is, even if there is everything else normal, it will indicate that there is a gas exchange abnormality precipitated by extreme of exercise in an individual, a very common finding to be seen in patients with pulmonary hypertension. Only isolated abnormality, because most of the time they are considered as a hysterical patients initially. So this is the graph. You can see all these graphs put together. And so we see that the first one is basically looking at the VE, or the oxygen utilization, VO2 uptake. And then we look at the cardiovascular parameters. You can see the cardiovascular parameters. Then we have ventilatory parameters, which is the panel number 4 and panel number 7. And again, the gas exchange parameters versus ventilatory parameters are all of them, in which you can see not only we have the the ventilatory equivalent, end tidal oxygen and carbon dioxide graphs. We have VCO2 graphs. And we also have a heart rate versus VCO2 graph. So all these panels are trying to tell us some different information. So that is why it is considered as they have been chosen to be kept like that. That brings us to, if you have all these graphs in your hand and now you want to interpret the report, how to go about it. So these are the 4 steps. And as I said that right in the beginning, the step 1 is to find out whether the test was maximal or not. If it is sub-maximal test, you will write that the test has not been performed to exercise capacity and hence cannot be interpreted. So the test has to be repeated in that case. So what is the criteria? One of the criteria I told you is the respiratory exchange ratio, which to start with is 0.8. We all know that oxygen carbon dioxide ratio 0.8, and it increases with the exercise to beyond 1.15, generally 1.1, 1.15. So if it is like less than 1 or 1, then obviously the exercise test is not good. Heart rate predicted maximum, you need to reach 90%, but you go even beyond 90%. Last time I told you, we do not terminate the exercise test just because the predicted heart rate has achieved. This happened in treadmill tests. In the treadmill, cardiologist will achieve that heart rate maximum. It has reached 200, they'll stop the test. But this is a maximal exercise test. So it is not necessary. You will see that predicted 180, we have gone up to 210. So heart rate is not a termination criteria unless and until patient complains of something related to that. If the cardiac arrhythmias are thrown, fine. If patient complains of chest pain, fine. But just because he has achieved that heart rate is not a termination criteria. But if it is not even 90%, then obviously there is something wrong with it, that not performed fully. Board scale of dyspnea is very important. He must complain that he is very, very dyspneic. So 8 by 10 is generally considered as a criteria to terminate the test. So patient, whether he has achieved VO2 max or is it the VO2 was still achieving and it is not plateaued at that point of time, that is again needs to be seen. So, but by and large, all of these are the ones which we need to consider. But now since the spirometry is along with the CPET and it is called ergospirometry. So you can also perform a spirometry during the exercise and then see that whether it has got a flow limitation or not. And I'm going to show you the graph of that. So once you have done that testing in step 1 that it is adequate and good test performed, then you go to the number 2 step, which is required to look at the VO2. Is it VO2 peak which is acceptable? That is up to 85%. If it is less than 85%, there is exercise limitation. And then you come to step 3 to find out what led to this exercise limitation. What was the dyspnea? Why was the dyspnea? Why was the exercise limited? Was it respiratory? Was it cardiac? What is pulmonary vasculation? What is circulatory? What are muscular, poor conditioning, patient's poor effort, all these, or anxiety and hyperventilation, all these are different set of things which can be diagnosed once you have achieved that level where you need to come to the step 3. And this integration is all done in step 4 because one single parameter will not get the answer. That's why there are panels. You now start to put the panels together to make the interpretation there. So this is the CPET test which is being done. I think last time there was a request to show how the test is being done. You can see that there's a monitor which is trying to look into all the parameters. You can see breath by breath analysis is coming. So I think Raja, I said in the, you can see the VO2, VCO2s breath by breath in there. So suddenly they change, they tell you. So these are the old machine. The new machine has ECG and blood pressure and saturation ongoing on the machine itself. This is the bicycle ergometer. You can see that the patient has been given 54 watts to perform. 10 watts are going in 2 minutes up. He started doing the exercise. Non-invasive cough is already there. This is basically the sensor. So this sensor with the mask includes the CO2 sensor, the O2 sensor, and a volume sensor. So you will keep getting breath by breath analysis through this sensor only.
क्या कोई दिक्कत होना भी कोई नहीं ठीक है आप चलाने में ध्यान लगाओ
So this pedaling has to be done at speed of 60 cycles per minute, actually, per second. So, sorry, per minute. So that is the speed which needs to be maintained on the cycle. That is equally important. So if he does pedaling very slow, then he will not be able to achieve his wattage which is required. So watt is calculated from the speed which is there on the cycling. So that is seen onto the monitor of the cycle, which is telling us that he is able to do it according to that 50 to 60 which is required. So this is the maximal test which I told you, 1.1 heart rate maximum, which we have already discussed. And then if the test is done good, this is 8 by 10, which I'm trying to show you here again, that this is the other graph where you need to be around 17. You need to be on very hard that it has been done. And this is done separately for leg fatigue as well as for dyspnea. So you need a Borg scale to be done for both of them. And of course, there can be other clinical exhaustion factors like patient profusely sweating. But this all is to be achieved in 8 to 12 minutes. Generally, we never go beyond 12 minutes, and we do it to the can't do more. And this is the VO2 max. So you can see that this is the VO2 max. You can, the red line, you can see it is plateauing at this level only. So it has gone parallel to the exercise. It kept on increasing, and at the end of the exercise, it is paralleling there. So VO2 peak achieved is more than 83% or 85%, depends upon what you want to use, is very important. And you can see that starting with the 250 ml of VO2, which is 3.5 ml per minute per kg, you go almost up to 5 liters at strenuous exercise, which is about 70 milliliters per minute per kg an individual. So for that instance, we are trying to show you one record of the patient where it was 300 ml per minute at rest, and it was expected in this individual to reach about 1.6 liters. However, patient could not only achieve, this is about 600 ml. That was the maximum, which is about 37% of the predicted. So VO2, 37% of predicted means it is decreased. So exercise capacity is decreased. So this is the first thing which we examine from the graph which we get. This is the panel 3 in the Wassermann's 9 panel graphs. There is a linear relationship. As I told you, not only the VO2 max, but the slope. The slope needs to be 10 ml of VO2 per minute per watt. And you can see this picture which is trying to tell you that the slope is not parallel at all. It has just plateaued very easily. So this could be either because of the disease, heart, lung, circulation, musculoskeletal, or even sometimes even a poor effort in an individual. So these are the various profile responses. I think we have already discussed that they parallel with the work. And the PCO2 and the PO2 graphs, they go normally in linear fashion, but cross over at the anaerobic threshold points. Normal slope, then we are trying to upward displacement, which happens in obesity. And then we are trying to show you that with a slope which is towards the end of it, which is in coronary artery disease, and the very low slope, which is like a heart failure slope. And we reaches the step 3 after looking at the test done maximally. VO2 is low. Now we want to find out VO2 max is low or VO2 peak achieved by patient is low due to what? Is it ventilatory? In ventilatory, it is not only the ventilation which is important, but it could be also mechanics. So mechanics is primarily when the tidal volume encroaches upon to the inspiratory capacity in the expiratory limb, where the flow limitation occurs, which is, I think in the next slide will come up. But the ventilatory abnormality is when the breathing reserve is less than 20%. So that means that's the most important thing to identify. If we have the loops coming up with the spirometry, ergospirometer, then we also see that the dynamic hyperinflation progressively increases with the exercise, and patient is not able to perform because of the dynamic hyperinflation. The tidal volume plateaus early. The respiratory rate can be achieved about 50. Generally, we consider 50 as maximum, and heart rate peak is not achieved up to the predicted, and there is some amount of heart rate reserve left in ventilatory abnormalities. And if there is a patient who's got a severe respiratory disease, then gas exchange abnormalities will come with it. And gas exchange abnormalities are in the dead space ventilation, that is VD-VT ratio. Then there are also things like oxygen level falls down. The difference between the alveolar and the arterial oxygen increases because of more oxygen extraction. And of course, the PCO2 in peak also increases. So there is a abnormal gas exchange of oxygen, of carbon dioxide, and also of dead space, which are the indicators of gas exchange abnormalities. So you can look at this ventilatory limitation panel, which is trying to tell you here that the breathing reserve is calculated from the maximum voluntary ventilation into FEV1 FEV1 multiplied by 35 to 40, whatever you take in your lab, and that gives us the MBV. So you can see that the tidal volume is increasing, the minute ventilation is increasing, and how much it encroaches upon the MVV is the important aspect which we need to see. And as we discussed, that if it is less than 20% left behind, so that means that reserve was too low to carry on with the exercise, and there is a ventilatory limitation. And it also comes with the frequency range, which we'll see in the graph, the next one. You can see that this is the tidal volume graph which is being seen. This is, you can again see that in this graph what we are trying to look at is the ventilation, and it is within the range of various frequencies which are getting, and here it is becoming very flat, although it is still into the normalcy, but still it is becoming much flatter. So breathing reserve which is left at the end is very important. Like in this individual patient, we can show you here, he started he was expected to have about 28% breathing reserve. He started with at the 55%. So obviously he was already ventilating at a high rate at that point of time, and terminated the test when there was only about 9% or 8.5% breathing reserve left. So this patient who has terminated the test is because of the ventilatory limitation. So primarily the cause of dyspnea in this individual will be a ventilatory limitation. So these values which are considered as how much of ventilation you can get is also predicted, like there are different formulas that generally calculate by 85%, but by and large less than 40% VE max over MVV is considered at LT as a ventilatory limitation. So this is another one of the parameters besides the VE max minus MVV, which is generally about 15. We discussed about it, 15 to 20. On the other hand, we have another criteria where VE max over MVV is taken at LTT less than 40%. So that also we will see in the reports. It comes where we need to see. But this is what I was trying to show you is the mechanical ventilation, mechanical limitation. So you start doing the exercise where the tidal volume curves are small here, but because of the dynamic hyperinflation, you keep shifting, and finally the curve grows and crosses the limitation. So at that point of time, even if there is still breathing reserve left, but patient will feel breathless because he is encroached upon the flow limitation segment. So we don't only look at the ventilatory parameters, we also look at the exercise spirometry by showing the dynamic hyperinflation, which is shifting the tidal volume curve, and finally the bigger tidal volume curves which are coming now due to increase in exercise are encroaching respiratory limb of the flow volume curve, which shows that this is going to be limited because of it is encroaching onto the area where it will be uncomfortable for the patient to carry on with this. And these are the parameters for that, but this I think will be a little difficult to understand at the moment. But we go on to the second important part, which is the cardiac limitation. We know that breathing reserve is for the respiratory limitation, the two main things which we have discussed. But for the cardiac limitation, generally the breathing reserve will be present because these people are not stopping the exercise because the lungs were bad. So they had a breathing reserve left behind. However, the oxygen pulse, which is very important, is less. You can see that the achieved, you need to go about 80%, 85%, but the oxygen pulse is less than 70%. And again, you can see that the slope will change. This is what I was talking about. You can see the slope has come down. So even after increasing the exercise, the stroke volume, that oxygen pulse doesn't increase, and it sort of plateauing out. So this is again one of the indication or the flattening or the declining of this slope of the oxygen pulse that there is a cardiac limitation happening there. And there is also, if the heart rate response is not adequate chronotropically, what is called as chronotropic incompetence, we need to consider that also, which happens in patients with cardiac failure as well as patients who are on beta blockers. So the cardiac cause of dyspnea is very important. Seen on this panel of oxygen pulse, breathing reserve was for the ventilatory limitation, which was on the other side. Now these are again the things, sometimes you don't get it clearly, you anticipate. So two of the curves are being shown of the patients. You can see here as the exercise is increasing, the stroke volume, that the pulse is increasing and it reaches the peak. So that's fine. But sometimes it flattens. So if it flattens like that, that is an indicator that perhaps the stroke volume was not increasing as it should have increased, and you need to evaluate why did it happen. So is it probably because of the patient not able to perform because of his cardiac limitation, or there is an additional factor which could be even a vascular disease like pulmonary vascular disease there. And that brings us to the sixth question. What are the indicators? I think we go to Raja for this. I think there was a little cardiac as well as the respiratory. We have tried to concisely say that there are certain graphs which needs to be seen. Breathing reserve for the respiratory and the oxygen pulse, that is the stroke volume surrogate marker for the cardiac. But for the gas exchange, there is much more. So Raja, I think this question is a little more difficult, but then I think let's...
Sure. We'll also let you get your breath back. I actually, my link went for a minute or so. So when you were doing the CPET video, there's a question I think which is relevant, which I'll ask you and then go on to this question. So Dr. Radha Munje asks about the fact that lung function tests can be done by a technician. Do you think it's safe to actually allow CPET testing by a technician, or do you think a pulmonologist or at least a qualified doctor needs to be there? That's one. And then how many people have you seen collapsing while doing CPET, and whether it's a necessary requirement to have an intensive care backup when you do something like CPET testing in a hospital like yours or mine?
I think both questions are very, very pertinent, and they keep coming often in the talks on CPATs. So see, the incidence of the cardiovascular collapse in CPAT in the Western data is somewhere around 0.1%, which is very, very low. But it is mandatory that wherever the CPAT is being performed, the CPR full equipment should be available, and a physician needs to be present at that point of time. Having said that, we have never seen any collapse in, maybe we are doing CPETs from 2007 onwards, so it's been many years, and I think more than 3,000 CPETs have been performed. But it could also be one of the reasons that since we are attached to a cardiac institute, most of the patients have already undergone a cardiac evaluation prior to coming for their dyspnea not being corrected at that point of time. But I would still say that we have an expert, in fact, a cardiorespiratory therapist to perform it, not the technicians at all. They are not allowed at all. Even they are not allowed to do it. So they will also do it under a physician. And in fact, not even a simple MBBS guy, we will keep it, because initially when we start, we always have our senior resident present at that point of time. And the important point is when to terminate the test. So that's, I think, if you learn that, you won't let it go on to the level where the patient collapses. Both the questions were very, very relevant. You need to exercise caution. You need to have a physician. You need to have an equipment. In fact, NAB will not allow you to have a CPET lab without the defibrillator and a full equipment being present in the lab itself.
But brilliant exposition. I mean, I've seldom heard such a lucid explanation about the graphs that I have always found very difficult. So thank you, Deepak. So we'll come to the question. The question should be a cakewalk for you guys now. So the sixth question, following is the indicator of gas exchange abnormality in CPET. Is it a low anaerobic threshold? Is it a low oxygen pulse? Is it a poor heart rate reserve? Or is it a fall in oxygen saturation? Or is it an increase in the AA gradient? So this is straight out of what Dr. Talwar has told you. We've discussed this. So shouldn't be a challenge for you guys. It's a difficult question though, but he's talked about this through the course of this talk. So Deepak, I've got an answer. Interestingly, we are split out here. So there's about 40% of people who say that it's a low anaerobic threshold. There's 20% of people who talk about a poor heart rate reserve. There's 20% who talk about an increase in AA gradient. And then there's lower numbers for B and D.
Okay. So I thought gas exchange is a very good parameter to look at oxygen saturation. as oxygen saturation is the one which is going to fall as a gas exchange abnormality. This is a sometimes only abnormality on the CPET. Everything else is fine except the patient found to saturate more than 4%. And that's a clear indicator that there is a pure gas exchange abnormality. But when gas exchange abnormality is associated with cardiac limitation or respiratory limitation, then all others like low oxygen reserve and low AT will all come into it. In fact, if you get low AT with a gas exchange abnormality, then you start wondering on again pulmonary hypertension as a cause, because that will lead to a dual picture, because otherwise a gas exchange abnormality will not occur in patients with pure congestive cardiac failure. So or a coronary artery disease for that matter. So in fact, these combinations are very important to pick up certain diseases which are beyond respiratory and cardiac. And gas exchange itself never tells us it is primarily because of alveolo-capillary membrane, or it is the less oxygen uptake or a less oxygen utilization. Everything comes into a gas exchange. It's a very, very big area basically. That's why there are a lot of parameters. In fact, 50% of the Wassermann graphs are only talking about gas exchange abnormalities if you look at them. So this is a disease like pulmonary vascular disease. We said pulmonary hypertension. This is most frequently we have picked up on a CPET test when there is a young lady who comes with a dyspnea of unknown origin, which is primarily being considered as an anxiety. So when you look at them, they have certain cardiovascular abnormalities, like they have good breathing reserve. That will be there even in anxiety. But they have a poor stroke volume response. So the heart rate oxygen pulse is less than 70. They have this flattening of this stroke volume curve, and important are they have a gas exchange abnormalities. So you start looking at their echo and you find, oh, echo is fraction is fine, there is nothing wrong, this is no cardiovascular abnormality, it is anxiety. But the moment you look at gas, you will find that the dead space ventilation, which is supposed to improve with the exercise, we are supposed to improve VQ ratios with exercise. In fact, they are deteriorating. So if they are deteriorating, there is a gas exchange abnormality. Then if the CO2 increases at the end of exercise, that also is an indicator of bad gas exchange in the lungs. The widening of the gradient means that more oxygen is being pulled out. That also is trying to tell us that there is a gas exchange abnormality. And fall in PaO2 or saturation is again an indicator that there is a gas exchange abnormality. So combination of these two, which are both very subtle, will give a hint toward a pulmonary vascular disease and will lead to further right heart catheterization and picking up of these young ladies with pulmonary hypertension. In fact, we have picked up even a couple of doctors who have been diagnosed as an anxiety leading to dyspnea, and they had a primary pulmonary hypertension. This is a disease very frequently missed because most of the tests are normal and echo is also normal, and the PA pressures are not so high that they are picked up by an echocardiography. So they take a couple of years before they go and get finally diagnosed. But this test is really very good in this kind of a situation. So I think this is just to show you the gas exchange, all parameters are put together here. VD/VT, saturation, end-tidal carbon dioxide, oxygen, and ventilatory equivalents. All these parameters are looking at gas exchange, which is happening in these patients. So you need to carefully evaluate these for patients who are purely exhibiting gas exchange abnormalities.
Ventilatory. Can I ask you a question on the previous slide? So there's a question that comes in from Dr. Neeraj, and he asks, how does that gas exchange depicted by a DLCO compare to what you've picked up on that particular CPET testing?
Yeah, so I think it is a very good question again, Raja. What happens is if the diffusion capacity is less than 50% of predicted, it closely matches with gas exchange abnormalities, which you particularly the desaturation part, the saturation, the fall in oxygen saturation matches with that. But if the diffusion capacity is above 50%, in a routine exercise test, it may not be. In maximal exercise test, it does correlate with that. It does correlate with that. But by and large, on an exercise, it is not only the desaturation which we are going to pick up. So again,
yeah, we had a bit of a blip again.
Again, it happened. So I think what I was trying to say is that VQ mismatch is a very important aspect of looking at the gas transfer issues which are happening. So in pulmonary hypertension, that is why, because it's not only the diffusion factor which is important, but it is the VQ mismatch which is equally important in them. So that is why this is one disease where the more approach towards the gas exchange parameters is important for interpretation. But it does match with the diffusion capacity if the diffusion capacity is less than 50% in an ordinary exercise test. But between 50% to 80% of diffusion capacity, it will only come towards the end of the maximal exercise. It will correlate.
Thank you, Deepak.
So these are the ventilatory equivalents. You can see that typically at anaerobic threshold, they'll fall down and then they start increasing. And these are the patterns which you see. And these are the end tidal oxygen and carbon dioxide. Carbon dioxide should not increase. If it increases, it is again a marker of a gas exchange abnormalities, which it is trying to show in this situation. And there are certain other parameters of exercise limitation, like patient says, I have extreme leg pain, back pain. So these are primarily of peripheral origin. Anaerobic threshold less than say 40% we have already discussed. ST depression coming on ECGs, which is simultaneously being recorded, is all the time coming on the second monitor, is again important for coronary artery disease. And abnormal blood pressure response is again one of the important factor which tells us that the exercise has to be terminated, and this is the reason for the circulatory factors being responsible for poor exercise test performance. And you can see that this is how it comes. The BP response comes like this. At every step, these are the steps which are being given is when the load keeps on increasing. So at every step, you can see the BP is being recorded. You can see that 110 to 82 it started and reached 180 by 101. And you can see that the Bogue-Wass scale, it is going on, and you can see all the parameters of saturation and the ST segment depression coming up out here. So these are again on the records which are coming up. Even if you have not picked up during the exercise test, you can analyze again every 30-second parameters, or every 30-second data can be analyzed. So that brings us to the question 7, Raja.
Sure, yes, Deepak. So question 7, anaerobic threshold is characterized by, is it a fall in VCO2? Is it an increase in VO2? Is it a decrease in end tidal oxygen? Is it an increase in end tidal carbon dioxide? Or is it an abrupt increase in VE? So I think we've gone through all of this. We've spoken at length about anaerobic threshold. So haven't got an answer yet, Deepak, but we'll try again.
See how important is anaerobic threshold is clear, because there is not one method to calculate. There are in fact 6 methods to calculate it. So, and this is very important in the test for the person performing the test to find out whether AT was achieved or not. It may not be visible on one of the graphs, so that is why there are so many graphs need to be analyzed.
So Deepak, about 2/3 of people have said it's an increase in end tidal carbon dioxide, and 1/3 have opted for decrease in end tidal oxygen.
Okay. So carbon dioxide will increase, that is true at anaerobic threshold, but what will match with that is a ventilation, which is the most important thing, I think. The carbon dioxide, there is no problem, and you need to get it at level very high, above 40. And you can see it is achieved here at a very low level in 3 minutes of exercise, which would be like not even 20% of it. Very early it has been achieved. So you can see even the graph is bad here, which tells us. So these are the other graphs which I have showed you. Again, the same thing. You can have a ventilatory graph, which is very important. CO2 graph, again, the slopes are being shown here. And this end tidal one. So end tidal ones are actually, they decrease basically. You can see that they are decreasing. The CO2 increases, yes, but then it starts decreasing again. But these are basically decreasing. Now what we are talking about is basically the ventilatory equivalents. So they will decrease towards because the ventilation will become more efficient. And the moment it becomes less efficient, that is the time when it will start rising again. So that's why these values will fall down with the exercise normally. So step 4 is putting all together. Achieved normal VO2, whether AT was there. If AT was there, it is low or normal. Is there a cardiovascular limitation? Is it ventilatory limitation? Is it a gas exchange limitation? Or it is a combination of cardiorespiratory limitation or cardiac and a gas exchange limitation, or a respiratory and a gas exchange limitation? And very importantly will come either it is poor conditioning, or there is a, like patient is deconditioned, or there is some muscular limitation or a poor effort. So all of this has to be put together in the last step when we start interpreting. So this is a little complicated graph. I think I've just put it because the slides will be available to you people. You can go through it. But again, it is trying to tell you the same thing. Look at two reserves, the heart rate reserve and the breathing reserve. If the breathing reserve is not there or reduced, which is expected to be like 30%, then obviously there is a ventilatory limitation. And at that point of time, the heart rate reserve will be still there. So if the heart rate reserve is not left behind, it can be a cardiac limitation, no problem. You need to go ahead and look at the oxygen pulse, which is the stroke volume. If that is flat, it is okay. You try to look for the anaerobic threshold. If anaerobic threshold also came in early, then obviously it is a cardiac limit. If the if the oxygen pulse is okay, but the anaerobic threshold came early, then that is a muscular factor. Then there is a muscle issues, and the patient needs to be evaluated for his muscular myopathies or perhaps a poor conditioning, which is again a very important cause. So by and large, these 3-4 things are very important, and then comes the gas exchange abnormalities. So that brings us to the question number 8 about the respiratory limitation. Raja?
So yeah, sure, Deepak. So what is the indicator of respiratory being the limiting factor to exercise in COPD? Is it a decrease in respiratory reserve? Is it termination of CPET due to dyspnea? Is it early anaerobic threshold? Or is it normal ventilatory efficiency? So Deepak, while we are waiting for that question, I'll quickly address something else that people have asked in the meantime. So people have asked that you've talked about various surrogate markers for acidosis in the way of anaerobic threshold. You've talked about the end-tidal carbon dioxide, the end-tidal oxygen as surrogate markers of PaO2 and PaCO2. So people are asking whether it can replace an ABG completely, or do you still in some cases need an ABG as a part and parcel of a CPET testing?
So Raja, we don't do the ABGs now, because what you need to put in is actually an arterial cannula to draw the ABGs every 2 minutes in them, and that disrupts the exercise test itself, because if the patient's attention gets drawn at that point of time, they start hyperventilating and things like that. So initially, you know, when we were trying to calibrate the machines and our own experience, couple of tests we even did with the cannulas there, and many times we even put in a PA Swan-Ganz catheter, because some of the patients who had Swan-Ganz, you can actually calculate the cardiac output. So you can have a stroke volume, you can have a cardiac output, and then you try to match it. By and large, the values are like 5% up and down, and since it is the response which you are looking at rather than a single value, so there is no point in doing the invasive. Actually, if you do these invasive parameters, then the entire the idea of doing CPAT as a non-invasive test is gone, completely gone. So that is why I think that we should keep all the invasive things as less as possible. And arterial blood gas, and there are people who have done even with the PA catheters to looking at pulmonary circulation, cardiac output, and pulmonary vascular resistance. But ultimately, they make the things more complicated and doesn't help you much. So that is why to make it simple and less invasive as far as possible is the beauty of the test, I suppose.
Sure. So thank you, Deepak. So I've got responses now. So again, it's a split again. So indicator of respiratory being the limiting factor to exercise in COPD. The largest number have talked about decreased respiratory reserve, which is good, I guess. There's a 30% people who've talked about early anaerobic threshold. And then there's 20% who've said termination of CPET due to dyspnea. And then there's about 10% who've talked about this being a normal ventilatory efficiency.
Okay. So I think I'll quickly tell that people, large number have already picked up correctly. It is the respiratory reserve. Always the respiratory reserve is the important aspect in the respiratory limitation. Dyspnea may be reason for termination of CPAT into any cause, whether it is cardiac or anything. So it does not matter. early anaerobic threshold does not happen in respiratory disease. The problem is the anaerobic threshold doesn't happen in respiratory disease because the test is terminated too soon. Like sometimes we calculate these people, they are only able to do 50 watts. So what we need to do is practically we need to give them less than 5 watts per minute, so to able to achieve that 10 minutes of exercise test, and they terminate the test at 7 minutes. So at 7 minutes, they are still in aerobic metabolism. So anaerobic metabolism hasn't happened at all in respiratory cases. So in patients with COPD, it is very difficult to elicit anaerobic threshold in them because they do not do the exercise up to that level. They terminate prior to that, and they terminate because there is no respiratory reserve left in them. Because their FEV1 is like 30%. So you multiply with 35 and you get to MVV, which is so low that it is almost, and the basal levels are already high. They are already 800 ml. So the moment you start increasing it, they reach 1200 and finish. The test is already finished. So that is why it is very difficult to perform 10-minute test to them to look for anaerobic threshold, because it is very important. If it comes early, then there is an associated cardiac limitation in them. That becomes very important. And ventilatory efficiency is a gas exchange parameter. It can be there in severe COPD also, no doubt about it. But it is primarily indicating that how well the lungs are able to handle increased carbon dioxide. And obviously, the lungs which are poor will not be able to do a good ventilatory efficiency there. So this is like a chart which we are trying to show. So you can see here, the important aspect is that you can see that there is no breathing reserve left here. It's just finished. So then you see the ventilatory response, which is also acute. You can see that anaerobic threshold has come in. The gas exchange abnormalities are again coming in. So this is like a pattern which you get in patients with COPD. This is a COPD pattern. That brings us to the next question that which is here. Raja, you can see.
So Deepak, disease specific questions. We've got some, so last 15 minutes, we've got some very interesting questions from not just the country but outside. So we need to keep some time for that. So quick comments from you, Deepak, after the question maybe.
So I think we can rush through these questions.
Yeah. So shall we do that? So indicator of respiratory being the limiting factor for exercise in interstitial lung disease here. So is it termination of CPET due to dyspnea? Is it early anaerobic threshold? Is it normal ventilatory efficiency? Or is it an increase in the PO2, so alveolar arterial gradient at the end of exercise? So which one do you think is the right answer? And Deepak, maybe a couple of comments while we are waiting for the answers to come in.
So I think now you see that interstitial lung disease, when we are talking about, it is a gas exchange abnormality we are talking about. So the important issue will be the dyspnea again is going to be there everywhere. It's going to be all. Early anaerobic threshold will mean only again a cardiac limitation or a very, very poor muscle power of the patient. So you need to consider that in those situations. Ventilatory efficiency is going to be poor in interstitial lung disease also. So I think we can move on to quickly to the next one, Raja. Is that
Sure.
Because I think for sake
the audience has got it right though. So brilliant. So let's go to the next one.
So you can look at this, see these the gas exchange abnormalities are the most important things which are happening. And these are the graphs. You can see end-tidal PCO2, PO2 graph. As I told you that these are the gas exchange abnormalities, ventilatory equivalents which are abnormal in this situation. And you can see that in this situation, although this cardiac graph is actually going on here, but there is no clear-cut cardiac limitation which is coming in. But yes, there is an anaerobic threshold which is coming up here. So we move on to I think we'll leave this one or two questions which are really more difficult, like pulmonary hypertension. We may come to something like heart failure. I think this is important. We can go for this.
Sure. So indicator of limiting factor to exercise in congestive heart failure. Is it termination of CPET due to chest pain? Is it normal anaerobic threshold? Is it normal ventilatory efficiency? Or is it shallow oxygen pulse slow? And again, Deepak, you've spoken about this in length. So maybe a carry home message for the audience about congestive heart failure.
Yeah, so I think we had for the respiratory breathing reserve. So we have another one very important here, which we have already discussed, which is a surrogate marker of stroke volume is an oxygen pulse. And that's what we are trying to show you in this graph. You can just look at it. It's just flat. It did not rise at all, actually, the oxygen pulse. So when you look at the straight graph of stroke volume, it gives you an idea that nothing has happened as far as this is concerned, and the heart rate was the only one which tried to increase the cardiac output there. So this is a typical graph of what we get in a cardiac disease.
And Deepak, you'll be happy to know that people have been listening to you. That's 100% answering the oxygen pulse. So
Great.
Brilliant.
So you can see the early 80 also here. You can see that it has crossed very early. So early 80 and all these things together are there. But then you need the basic ones to look into that. So I think we can leave the other ones. I'll quickly come to this last algorithm to interpret that. You look at the peak VO2. If it is less than 80%, then obviously there is some exercise limitation. You go down the graph. But if it is more than 85%, anxiety, obesity, and a very mild disease can still be there. Obesity can be corrected when you correct the VO2 by per kg. Anxiety, you can look at into the VCO2 graph, V over VCO2 graph, which will show hyperventilation, but which shows that there is excessive ventilation, which is washing out carbon dioxide. When you look at the low, you look at immediately anaerobic threshold. If anaerobic threshold is low, you look at the breathing reserve. If the breathing reserve is also low, then there is a mixed disease, cardiac as well as respiratory. But if breathing reserve is normal and anaerobic threshold has come early, then this is a circulatory cardiac impairment which we are talking about. On the other hand, if the anaerobic threshold is normal or it has not been achieved and the breathing reserve is low, then it is lungs. However, if it is achieved, it is normal and breathing reserve is also normal, then either patient has not put in enough effort. You immediately go back to RER, see whether it is more than 1.1 or not. Deconditioning can be very important here. Again, the stroke volume graph, O2 pulse. If the O2 pulse is good, then it is deconditioning, not because of the heart condition. And now look at the ECG if it is because of the coronary artery. This is the American Heart Association thing which is coming up. So we can have the questions now, I think.
So Deepak, that's brilliant. So from that, the last algorithm that you've got on the screen there, Deepak, I guess there could be overlaps, isn't it? And I guess overlaps will make it more difficult. So overlap of airways disease with coronary artery disease.
Yeah, very true, Raja, because the life is not that simple as the American Heart Association has made it. They have made it like you only look at two things. You look at VO2, you look at anaerobic threshold, you look at breathing reserve, and that's the end of it. It doesn't happen that way.
Sure. So Deepak, we'll take just a few questions. There's quite a few actually. So we'll take a few. We've got about 5 or 7 minutes left. So Dr. Radha Munje again asks a question which is related to safety. So COVID times, what about filters or sensors attached to the mouthpiece when you're doing the test? Are you using them at Metro, or are you sort of going the conventional way?
Yeah, no, we are using the wire filters. They were there before also. And we did confirm that it's basically during the COVID times, it's basically the mask. And the mask has to be sterilized every time in individual patient. The same mask cannot be used again. So it's entire, and the gases are actually, they are going through a filter into the from the mask. They outside the mask, if they have to come, they come through a filter. So basically, if you think that the breathing pattern will breathing in this mask will lead to dissemination of the virus because there is a filter, and that filter is again the same viral filter which we use for our body box and other equipment also, and that's good enough for using it actually. But as a standard protocol, we after every test we open the windows, let them be all sanitized, and then restart again. But mask has to be sterilized. In fact, it is ETO. It has to be ETO'd every time we use it. So we have couple of masks. If like we have to do 2 to 3 cases in a day, so 3 different masks will be used, and then they'll be sent for ETO. They'll be all sanitized, and then only they'll come.
So just like the PFTs, you would actually have about a half an hour, 40-minute gap between individual procedure for sort of aerosol dissemination, right? Okay, great.
That, yeah, I do not know how good it is, Raja. You only know it.
Yeah.
But we follow this at the moment.
Yeah, sure. So we do the same for our PFTs. So there's this question about blood pressure and what sort of rise and what sort of fall is significant. So Dr. Mohammad Rahim Hussain has asked that question from Sikandrabad. So what's relevant? What blood pressure rise or fall would be relevant to you?
Okay, I think it's again a very pertinent question, because in fact the BP response is one of the indicators to terminate the test. And what is that BP response? So when the BP shoots up to more than 210 of systolic and more than 110 of diastolic, we stop the test. That's the criteria for stopping the test because of the abnormal hypertensive response on an exercise. And we do report it that this patient had a response. Patient may not be hypertensive, but has a hypertensive response. What does it mean? It means a poor sympathetic response in an individual patient. And fall in blood pressure is very, very significant. You need to immediately terminate the test. So if there is more than consistently, if there is more than 20 millimeter fall in systolic blood pressure, again we terminate the test at that point. So sustained means that 2 consecutive readings.
Right. So there's another question which is actually from an international audience, Deepak, and I'll finish off with that. So there's Dr. Mohammad Abdul Bais from Dhaka, who asks about an alveolar arterial oxygen gradient, which might be due to an intrapulmonary shunt. And is there a way of picking that up on a cardiopulmonary exercise testing?
Yes, very good question, but very difficult. It can be picked up by looking at other gas exchange abnormalities associated with it. Then intrapulmonary shunt or intracardiac shunts can also be picked up by that. This is a little more sophisticated because then you need to calculate the slopes. So I didn't include that. I think for that we need to have far advanced CPET.
Sure.
Where individually every graph, the slope is calculated. And if the slope doesn't come up to the level of the gas exchange parameters, that is calculated for shunting of blood. It is possible, yeah.
Grand. So I think we'll leave it at that, Deepak. So thank you very much. I actually learned a lot there. There's lots of messages here where people have said they've learned a lot in the last 2 hours today. So thank you. Thank you very much for the entire module, but especially the advanced CPET one, which I actually, like I said, learned a lot. The Indian Chest Society is very pleased to be endorsing a program like this. And I hope there'll be a time in the not so distant future when we'll have more programs like this coming from your side.
Thank you, Raja. But I'll tell you one thing. The entire audience must admit this thing, that I couldn't have got a better moderator than Raja himself today. With a very, very, I was not very sure that how to approach you for this. But let me take the courage and ask Raja for it, because there are certain people who will take the challenges and will definitely tread onto an uncomfortable. This is an uncomfortable zone. Every time I come onto a CPET platform, it is uncomfortable for me because I have to talk so much, and people will get boiled by these graphs the moment they see it, and it is very difficult on this kind of a platform. If it's 1-to-1, then it becomes very easy to make them understand those kind of graphs. But this kind of a platform, it was difficult on an advanced CPFT. And on the top of it, getting Raja was my challenge that I wanted, and he agreed. On the first instance, he agreed. So I think I have no words to express my gratitude to come on this thing today and wonderfully help me to pass through this difficult test of doing this CPET advanced course today. Thank you, Raja. Thanks a lot. Thank you everyone for being with us. And with this, we come to an end of this series of 4 advanced lung function tests. Thank you, everyone.
Thank you very much. Thanks. Thank you very much.